regression was only observed in 37% of patients and even progressed in 10%. And also interestingly to see that it's interesting to see that even after some regression, after that they developed again the TR and in a long-term journey follow-up. The factor associated with TR progression include again atrial fibrillation, right heart dilatation, right atrial dilatation, and pulmonary hypertension. So really, right ventricular function is the key factor in patients with tracheal rigors. The question is how to assess, how to evaluate. Obviously, our first choice is echocardiography, and this is really non-invasive method, and you can repeatedly measure. So obviously, the first choice and the several measurement have been used in this area. This parameter has strong and weak points. But I do believe that the multimodality is really essential to evaluate right ventricular function in this area to enhance the prognostic stratification and estimate potential benefit of TR treatment. One of the most common measure of RV function remains TAPSE, tricuspid underplane systolic excursion, which is actually longitudinal shortening of the right ventricle. And however, this data from TRIVALVE registry suggests that the conventional echocardiographic parameter alone, TAPSE alone, did not predict outcome after intervention in patients with TR. However, the combination of TAPSE and RV fractional area change, for example, which refer to circumferential systolic function of RV, may be more useful for predicting outcome in this area. This is a retrospective analysis from Bond, and actually 70% of patients had RV dysfunction, which was defined as TAPSE less than 70 millimeter and also RV FAC less than 35%. Importantly, here was really safe, irrespective of RV function. However, if you look at the 2 years outcome, a patient with RV dysfunction at baseline has significantly higher mortality. In addition to echocardiographic parameter, cardiac CT is also variable tool for assessing RV function. This is data of 157 patients undergoing TTVI, and 3D RV ejection fraction was assessed using the procedure cardiac CT, and 37% of patients present with RV ejection fraction less than 45%, which was associated with a higher risk of composite outcome. And also this association had an additional value beyond traditional two-dimensional echocardiographic assessment. So in addition to echocardiography, so CT measurement for RV function is really variable. And more importantly, not all patients, but some patients seem to have improvement in RV systolic function in the course of TR treatment. This is a retrospective analysis of 204 patients who underwent tricuspid TR and echocardiographic follow-up at 3 months after the procedure. There were RV responders, and they had a lower risk of a composite outcome compared to RV non-responders. And also the predictors for RV responder were smaller RV diameter and a greater reduction in TR. So that's why assessing RV function is really important and for risk stratification in patient with TR. The another important parameter is of course pulmonary hypertension, and guidelines, American and European guidelines says that pulmonary hypertension should be evaluated, and at least severe pulmonary hypertension should be precluded from the TR treatment. Because firstly, pulmonary hypertension is actually common in patients with TR, and secondly, the patient with pulmonary hypertension have worse prognosis, especially if patients have precapillary dominant pulmonary hypertension. In the case of lighthouse catheterization, so you also can measure pulmonary artery pulsatility index, which is the parameter of RV function. This is a large-scale study of 5,000 patients with moderate or severe TR and pulmonary artery pulsatility index was measured. And they found that median PAPI index was a 3.0, and both the presence of pulmonary hypertension and decreasing level of pulsatility index was associated with more advanced level of right ventricular remodeling, higher NT-proBNP level, and also worse survival. And this similar association was also confirmed in patients undergoing tricuspid TR population. And the pulmonary artery pulsatility index 4 or less was associated with higher risk of the composite outcome after the treatment, which was independent of baseline characteristics or procedural success. The another variable true for RV function is so-called RVPA coupling. Because of the sensitivity of RV to afterload and index of ventricular contractility to afterload may further characterize RV function. So coupling describes a hemodynamic state where mechanical stroke work is well, and work is most efficiently transferred to the pulmonary artery circulation. In contrast, uncoupling suggests the RV can no longer maintain forward cardiac output. There are a couple of parameters of RVPA coupling, but TAPSI divided by pulmonary arterial systolic pressure is the mostly used parameter. This large-scale cohort study investigated that RVPA coupling as measured by TAPSI divided by pulmonary arterial systolic pressure, and they found that the cumulative 5-year survival rate was lower in patients with RVP uncoupling and compared to their counterparts. So RVP coupling is associated with outcome in this population. And also the similar association was observed in tribal registry. The data show that RVP coupling measured by, again, TAPSI divided by PASP was associated with decreased risk of all-cause mortality with cutoff value of 0.406 in patients who underwent TR treatment by catheter. And also importantly, the magnitude of TR reduction after the treatment was independently associated with a reduction in post-procedural RVPA coupling. That is, patients with afterload reserve who are characterized by high procedural RVPA coupling ratio have sufficiently preserved ventricular contractile function to tolerate increased afterload even after TR treatment. However, pulmonary artery pressure can be underestimated in echocardiography in patients with TR. So Philip Lutz demonstrated that there are so-called discordant patients who pretended not to have pulmonary artery hypertension, but indeed they had, based on the right heart catheter. These patients had impaired right ventricular function and more severe TIA and worse clinical prognosis. And actually, RVPA coupling parameter can also be measured using the combination of echocardiography and invasive measurement of pulmonary artery pressure, which is more accurate, um, and especially in patients with massive or torrential tear. This analysis showed the improved predictability for outcomes after integrating invasive measurement and RVPA coupling. The RVPA coupling parameter or whatever other RV function measure may be even more important delineating factor in predicting whether TIA treatment is beneficial or futile in patients with TIA. This is a retrospective analysis including 744 patients who underwent mitral TIA, and we found that severe TIA was observed in 22% of patients. Of course, the severe TIA was associated with outcome, but importantly, the impact of TIA, prognostic relevance of TIA was pronounced in patients with high TAPC pass ratio, namely a couple patient, but attenuated in patients with low TAPC pass, which is namely RVPA uncoupling patients. The trends were also consistent in the multiple regression models, Brancos, and other sensitivity analysis. So prognostic relevance of TL may vary according to TAPC path. And similar trends also have been observed across multiple study and registries, and suggesting the potential interaction between RV function and the benefit of TIA treatment. More specifically, the patient with better RV function appears to gain greater benefit from TIA treatment. The similar finding was also observed not only in cohort study, but also in RCT. This is post hoc analysis of TRISCEND 2 trial and showing that there was a significant interaction between right ventricular fractional area change and the change in KCCQ score, namely patient with greater LV fractional area change shows larger increase in KCCQ score. Yes, so let's move on. Of course, the other important factor is TR reduction. This is just analysis of 3-minute pivotal trial. The magnitude of TR reduction was associated with QOL improvement, and the Arnold has shown that QOL improvement was associated with lower risk of heart failure, hospitalization, and mortality after looking at the combined cohort, 3-minute pivotal rolling cohort, and also 3-minute early feasibility study. So this is the data we all know that present at the ACC currently. So I believe that to improve to improve outcome in patient with TR, the procedure must be safe enough, and also we need to reduce TR as much as possible. Most likely a mild or less, and also the magnitude of TR reduction globally at least 3 grades. And for patient selection, RV function at baseline may have to be preserved, or at least patients with severe RV dysfunction might have limited benefit from the treatment. This is another topic, lung disease and territorial ligatures. Lung disease also common in this patient. I may skip this slide because of the time. Yes, COPD is common and which is associated with outcome, but important to say that it just because a patient have a COPD, it doesn't necessarily mean that TIA treatment is futile. The patient may have benefit from TIA treatment. So earlier intervention assessing RVP coupling, evaluating comorbidity are key to enhance prognostic risk stratification and also to estimate potential of TIA treatment. Device selection is other topic, but I will skip this. And this is the last slide of the presentation. And interaction between TLRV function and pulmonary artery circulation. Multimodality to assess RV function is key, and RVP coupling is paramount for assessing RV function in TL patient, as well as the extent of TL reduction. RV function, including RVP coupling, may be a delineating factor for the potential benefit of TR treatment. With that, thank you very much.
Thank you, Atsushi. This was a really great talk. You published so much, all the literature for almost all of it was from your group. And this is why we invited you to present on this topic on TTVI selection. Also, I wanted to let you know that you recently published this article on JAK intervention. We wrote the editorial for you. And I have to say, a lot of people are asking us about your study and how you identify these patients. So maybe I will ask with a question for you, and then we'll see if the other people have also questions for you. So now you're in Japan. Before you were in Germany. Are you still applying the same selection process in your patients? Has anything changed, especially regarding RV function? Have you noticed any difference in your patient population or your device selection?
Yeah, thank you very much. It's such an important question. So I'm still looking a patient with a tear in Japan, and also probably I may start just talking about anatomy of tracheal ligatures because the patient in Japan, patient with tear, they tend to have a larger or large atrium and also lesser atrium. Probably they might have some sort of different prevalence of the HRD of tear, and also the anatomy. For the anatomical point of view, they tend, because patients are little bit have small body size, they tend to have probably because of that they tend to have a smaller or shorter septal leaflet, which is and I noticed. And for our RV function, we are currently looking for the opportunity of the MRI and also CT measurement for assessing RV function. And also currently I'm being so curious about exercise induced RV function in patients with TR. So, but we are still investigating.
Thank you so much. Dr. Latif, would you like to?
Atsushi, as always, great work, and congratulations on all the research and publications you did while you were with Georg Nikonig and the team. I hope you continue to do it in Japan and continue your research, and good luck with that. So let me ask you, a couple of things. While you were there and in your research, this is one of the largest tricuspid centers in the world, and they still are, and they had access to many technologies. I mean, we're talking about RV function, but maybe I want to maybe just simplify it down for the clinician. How often did you see patients who developed acute RV failure after a tricuspid procedure, in your practice?
After tricuspid H2H repair, we hardly seen such patient with acute RV deterioration, to be honest. But we
What about
had
after TTVI?
you mean replacement?
Yeah,
We had a couple of patients.
yeah. And
Although they had really preserved RV function at baseline, we didn't expect that.
okay, so that's interesting because that's something we see as well, is that you can't always predict it, because you again there are all these markers, right? And you talked about fractional area change, we talked about TAPC, you talked about RVPA uncoupling, but you know for me as the clinician, or for the clinicians listening and the fellows, they see a patient in the emergency room, has severe TR, and they're wondering, should they refer the patient for intervention? They're looking at the RV. I often don't know how to advise them, because obviously, I mean, the reason we talk about this, there isn't one marker that says, okay, you measure this special index, the Sugiura index, and now you will know if the patient his RV is gonna collapse or not. So I mean, what do you think? What's your advice in how we try and really ascertain and distinguish and differentiate the patients who may benefit or who may have trouble with a tricuspid valve intervention?
I do believe the patient who benefit from TR intervention is certainly those patients who have really preserved RV function at baseline,
Yeah.
and is not so much dilated,
Yeah.
and also a certain severe TR, I mean massive or torrential TR, and also you can reduce a TR really well, also mild or less. This is a really a good target for TR intervention, I believe.
Yeah, I guess what I struggle with is just what the other side is, right? The extreme. I mean, I think patients with small gaps will do well with TIA, right? But what is the other extreme? And when is it we say a patient is too sick for a tricuspid valve intervention? To me, that's usually comorbidities, and it's anatomy, and then it's RV function, right? Those are the three things usually where
Yeah, yeah,
they
yeah.
say this patient is no longer, because there's a lot of research now, and it's great. We have all this research about how we're learning more and more about the natural history. We're learning more and more about how RV function, like you showed in multiple studies, is an independent, predictor of worse outcomes, mortality, hospitalization. But I still not sure I fully understand, like, what's the sweet spot of patients. You mentioned it very briefly, you want severe TR, but the RV shouldn't be too bad. But what is that sweet spot where we actually will have more than just quality of life improvement, where we'll improve also heart failure, hospitalization, maybe even mortality?
Yeah, probably if I mean, of course, you need to think about the three components as you mentioned. The first one is the flaridity or comorbidity of patient. The second one is anatomy, and the third one is RV function. And if basically, I would say the patient are flail or to have too much comorbidity, or a patient have some sort of RV dysfunction. I would say the non replacement, so repair technique would be feasible uh, because it's pretty much safe. And even after, for example, let's say angioplasty technologies, obviously the TR reduction is not so much, but you can also add H2H repair after that. And also this is quite safe and to reduce the TR and while watching the RV function.
Right.
And yeah, and
Pierre, Any comments?
Yeah.
And then I have one more question for Atsushi.
Yeah, Atsushi, thank you so much. Fantastic. Thank you. Lots of evidence.
Thank you. Thank you very much.
I've just a couple of questions, real quick. So, we have a few indexes now in the panorama. If you were to have to pick one, which is the most reliable and the one that is giving you the most information to choose, number one, if a patient is candidate for any kind of intervention, and number two, if the patient is candidate to TTV repair rather than replacement, which one would you choose? And also, like, just wondering what your guys' experience was and is so far with the primary TR, if you guys have had any different behavior in, patients presenting with different mechanism, carcinoid, or anything like that. Thank you.
Yeah, thank you very much. I will start with the second question. For primary tier, the patient we recently just published the article, and their patient with a shortened and thickened leaflet, which is also primary tier, or probably because of a carcinoid or so something. This patient is not a good candidate for repair, H2H repair, so good for replacement. But on the other hand, the just flail leaflet or belowing prolapse, which can be this can be a really good, well treated by H2H repair. What was the first question? Sorry.
So the first question was, you went through various indexes throughout the presentation. I'm just wondering, in your clinical practice, I guess we gotta mix them up all together. And I'm just wondering if one of these is, having more weight for you in your clinical decision making with respect to a patient being a candidate for any procedure, and in case it's a candidate for a procedure, being a candidate for repair rather than a replacement, or vice versa.
So you mean the device selection between repair and the replacement?
Oh yes. How do these indexes affect your decision making for this kind of decision, on top of having the decision of a patient being a suitable candidate for any kind of intervention? Just how do you decide, and which one is the best and most reliable to you?
Which one among what? Sorry, I didn't.
Which among these indexes that we went through do you think
index
that
as a RV
yeah,
parameter?
Yeah. Which one of
Okay.
these parameters do you think is the most reliable if you had to choose?
TAFC SPAP. The second one is RV ejection fraction.
Okay.
The first one was what, sort of TEPC?
TAFC SPAP. TAFC PASP.
Okay.
Okay. And I guess that would be because you're taking into consideration both aspects of pulmonary pressure and RV function, and that might give you more information, correct?
Yeah, I believe definitely the information of pulmonary artery pressure or vascular resistance is really important, especially for the reaction of RV function to the intervention. So that's why I would say the perhaps the SPAP or RVPA coupling is the best parameter for that. And second one, because of the accuracy of measurement of the ejection fraction based on CT is good one.
Atsushi, you mentioned the paper by Philip and this group about the discordance between invasive and echocardiographic measurements. So just to let you know, we do invasive measurements in all our tricuspid patients, right? So I don't know if you do the same. In that case, what do you use for your assessment? Because you're saying TAPSI and SPAP, but the systolic pulmonary pressure might be different invasively. Do you adjust it? Do you change it? What do you use in these cases when you have both echocardiographic and invasive measurements?
Probably if yes, we do the analysis, and the discordant was more pronounced if patient was if patient had a massive or torrential TR, probably because the large coaptation gap one and also decreased velocity. That's why I would say that if patient had just severe TR, you can use the estimated echo parameters. But if your patient have massive or torrential TR, you need to go to the right heart catheter and see the pulmonary artery pressure to include the RVPA coupling.
Excellent, thank you. Dr. Ratib had another question, I think.
No, I just, again, it's similar to yours. And, the question that gets often asked is, in patients with severe TR and severe pulmonary hypertension, is there a level beyond which you shouldn't treat? Now, for us here in the US, obviously we mostly were doing these patients in clinical studies. We only now for a year have the approval to do it commercially, whereas in Germany, you guys were doing it for many years commercially. So I wondered if you could just maybe share your experience and some advice on patients with severe TR and severe pulmonary hypertension. What has been the approach in Bonn to those patients?
No, we did almost similar to other studies. Like if patient has a higher than 70 millimeter mercury of pulmonary artery pressure, we won't, or we didn't do procedure, but sometimes we did the procedure if the patient had a post capillary hypertension and some sort of borderline pulmonary hypertension. We try to improve patient symptoms.
Right.
But I know the current data from there was EuroTR was something there was the patient of post-capillary hypertension had also worse outcome as worse as pre-capillary hypertension. So I don't know. We need to investigate further.
Okay. So, okay, great.
Mm-hmm.
This is fantastic. And Ray, I'm not sure there are any questions from
I don't see.
faculty or the fellows. If not, maybe we'll close out.
Yeah,
We have a question
Hi.
here.
thanks, Dr. Sugiura. Sorry, I wasn't able to ask a question.
Thank you very much.
That was an excellent talk. I was reminded, when you were speaking about the sweet spot for TR patients, a little bit about the discussion we were having when COAPT came out, and we were comparing it to MITRA FR, and we said the patients that benefited the most are the ones that had MR that was out of proportion to their LV dysfunction. And I was kind of reminded of that when you were talking about your TR patients. Would you agree that this is kind of the sweet spot? These are the patients that have sort of disproportionately severe TR compared to their RV dysfunction, and should we be thinking about it maybe in sort of like a COAPT kind of a way in terms of the patients who might benefit?
Yeah. Yes, exactly. This is exactly, and as you mentioned, this is the idea, the large plan. So, but we need to see the also the other RCT data, and probably we need to, if possible, we need to combine the registry and also RCT data to see such association or correlation. But I believe there's such a proportion or disproportional TR and RV.
Yeah, great. And then my other question is what your thoughts about the design maybe of the currently available, which in the United States is just one, the Evoke TTVR, and future transcatheter tricuspid valve replacements, in terms of their relationship to RV function. We know that they tend to completely eliminate TR, which places a stress on the RV, but many of them also, just by their size and position and design, can also hamper RV function independently of the fact that they remove TR. So what do you think is the role for the design of future valves and keeping in mind the the RV function?
Yeah, this is such an important question, and very interesting to see the difference among the several replacement technologies. I do believe that there is there are several replacement technologies and with different anchoring system. And for example, the EVOC system anchors with oversizing to the annulus. And on the other hand, the cardio valve system is just sandwiching the leaflet, which may probably different impact on RV function. But it's a really interesting topic. We need to see that. Currently, we didn't investigate, so that's, yeah. But it's a really important point. Thank you very much.
Thanks a lot. Learned a lot from it. Thank you.
Thank you.
I think we have no other questions, so maybe we conclude here. I really wanted to thank you again. You presented really lots of data. We still have so much to learn, so we're looking forward to more studies like yours to understand a little bit more about these tricuspid patients, and hopefully we will see you again in the future.
Yes, of course, we will. Thank you very much for having me.
Thank you, Atsushi.
Thank you.
Thank you. Thank you very much.
Okay. Bye-bye.